So I hope you had some coffee to renew your energy for our session today. We've heard some exciting and inspiring reflections in the morning about the past 30 years, which made us who we are today and inspired all amazing actions that brought us here together in this room. We've also heard some reflections about some of the shortfalls we've witnessed over the past 30 years. And in the first session, we were asked, do you remember where you were 30 years ago? I couldn't answer that question because of a technical issue. I wasn't born then. But I asked myself another question, where I am today as a public and health and youth advocate. Where do I see myself today living in this world, and where do I see public health? And I found myself running into answers of things that I witnessed around me, some of which are the recent protests in Poland after a 33-year-old woman died because of being denied her right to access abortion. After living a horrific, isolating pandemic in which we all lost close ones, we still have to argue against anti-immunization rhetoric. And with rising migrants and refugees crisis, still the simple right to health is denied for people, and politicians are competing about the most horrific and inhumane ideas to address, in their opinion, the migrants' crisis. So today in this session, I have some news for you. We are not only going to talk about health, but we're also going to talk about politics. Yes, that's the spirit. So I have an amazing mix of panelists who I promise you on their behalf, although I didn't meet them yet, but that they're going to be honest. They don't promise to be neutral or sugar-coated, and they're going to talk politics. So I'm just going to welcome the amazing list of experts we have here today, starting with Jonathan Kennedy, who's a reader in politics and global health from the Center of Public Health and Policy in Queen Mary University. Peggy Maguire, who's the Director General of the European Health of the European Institute of Women's Health, and she was the previous IFA president as well. Please come to the stage. Yeah, Jonathan and Peggy. And also Michelle Levoy, who's the director of the Platform for International Cooperation for Undocumented Migrants, and also my fellow colleague and young professional, Naomi, who is a communication expert from IFA. So we will start by setting the scene of why we need to talk about health and politics, populism, and human rights today. And we're going to start with you, Jonathan. And if you can help us set us the scene and understand this. Jonathan, how do extreme politics and the rise of populist movements shape public health policies around us today?
Well, let's start by thinking about what populism is. And it's basically a political strategy that aims to divide the population into, on the one hand, an aloof and corrupt elite, and on the other hand, a virtuous people. So in the kind of right-wing form of populism, which I think is the most concerning to public health and the most concerning to Europe, the people are defined in a ethnic, racial, or religious way, and the elites are seen as some kind of globalist establishment. And in many ways, this form of populism is absolutely antithetical to public health and to a rights-based approach to public health. And there's a number of reasons for this. So, for example, it excludes a significant proportion of people within a country from the right to be treated with dignity and compassion, which is obviously really problematic. It portrays public health advocates, defenders of human rights, as part of this globalist elite, as part of some kind of conspiracy to defraud the people. And also, as we saw through COVID, often public health attempts to slightly curtail individual freedom in order to create better public health for the whole of society, and in particular to protect very, very vulnerable people are decried as kind of nanny state intervention. So we have to, as I think public health advocates, be really, really strong in our efforts to fight populism, and in particular right-wing populism. But I think it's also important to distinguish between the political entrepreneurs who cynically kind of push this ideology and the people that support them, because you know, in many respects there are good reasons why large proportions of the population in Western Europe have turned away from mainstream politics and political parties and have embraced this extreme ideology. And this relates to the failure of the center-left and center-right that have dominated politics in Western Europe for so long, and also the failure of economic and social policy, the inability to protect jobs and protect social welfare. So you know, I think it's really important to understand that this isn't just about some kind of post-2008 situation, that the kind of social and political and economic determinants of populism lie much deeper than this. And in many respects, the social determinants of populism are similar to the social determinants of health, which, you know, makes the problem in some respects more complex to resolve, but also more simple for us as public health advocates, because by trying to fight populism and trying to fight the determinants of populism will also improve public health.
Thank you, Jonathan. And this is such an interesting message, the social determinants of populism being related to the social determinants of health, which brings us to another discussion. And as a result of this growing movement of nationalism and populism around us in Europe, we are faced with the threat that public health is seen as a commodity rather than as a human right. And Michelle, what are the challenges as a result of this that vulnerable groups such as migrants and undocumented migrants and refugees face when public health is treated as a commodity rather than a human right?
So thank you for that. Here I wanted to start by saying two things. One, I think, is common to many groups and many experiences beyond migrants. And the second one is typically common to them, but then give some examples. So the first statement is that healthcare can be granted or retracted due to the overall political context. And the second one is the national government will try to instrumentalize health professionals in the fight against irregular migration by making them denounce undocumented migrants to immigration authorities. And I wanted to start off with that because I wanted to answer your question by giving some examples of how we've seen these two things play out in terms of health being a commodity rather than a human right. I think the first one is actually kind of a little bit, unfortunately, seen as a model for some countries, but is the UK hostile migration policy. So when Theresa May was Home Secretary in 2012, she gave an interview to the Daily Telegraph, and she said, and here I'm quoting her because she uses a term that we don't use at PICA, but here she says, "The aim is to create here in Britain a really hostile environment for illegal migration," unquote. We don't use the term illegal migration, we say irregular or we say undocumented. So what was this hostile migration policy? It was basically to cut off essential services, so healthcare being one of them, using the National Health Service as, in a sense, kind of like migration guards. Doctors, landlords, police officers, teachers were all asked to check immigration status. Thankfully, in 2018, the government suspended the policy after MPs, doctors, groups, and health charities warned that patients were afraid of seeking help. But that was kind of a very prolific and very visible and public example. Something that's not really that much known is what's going on in Germany, although those of you in Germany who are here might be aware of this. But basically, the German asylum seekers assistance law from '97 grants undocumented migrants the same legal entitlements to health as asylum seekers, which isn't perfect. isn't complete, but it is healthcare. But we also have a contradictory law, which is the German Residence Act, which was about 10 years later, which requires civil servants, including social welfare officers, to notify the immigration authorities or police when they come across an undocumented migrant. So the second law, in a sense, makes it almost impossible for people to get healthcare. What's promising is that in the German coalition agreement from December 2021, there's a pledge to abolish this duty to report, but we haven't really seen much impact since then. And another example from maybe some years ago is Italy in 2009, when it was looking at the security package at the time. There was a proposal to do the same. So to make healthcare professionals report undocumented migrants. And a lot of doctors, associations, healthcare professionals, et cetera, they made a huge campaign and said, basically, we're doctors and nurses, we're not spies. Thankfully, that was dropped. But here I wanted to also give you two more recent examples, and they're very worrying. So in Sweden, last year at the end of the year, the 2022 coalition agreement from the new government proposes that municipalities and other authorities report undocumented migrants to the Swedish Migration Authority. I'll come back to Sweden later, but basically in Sweden, undocumented children have the same right to healthcare as Swedish children, which is wonderful. Adults have care that can't be delayed, so a little bit more restricted. But with this type of proposal, it would be the same situation as in the other countries. So even though they have the right, they would be afraid of exercising it. And we've had a huge backlash since this proposal was made. It isn't yet formal. They're still discussing it, but we've had trade unions representing all the sectors come out against it. Directors of regional health boards, and an article signed by 4,008 healthcare workers who say, if the measures proposed by the TIDO agreement are implemented in the health sector, we'll commit civil disobedience, and we will refuse to report our patients. And the last example that I want to give is from Finland. So we also have a tend toward the right in Finland. We had parliamentary elections in April this year, and in the new government, the 4-year plan would have migration management measures, including the same. So the government would require reporting of undocumented migrants. This is really a shame because Finland was one of the most recent examples from last year that expanded its right to healthcare for undocumented. So about less than a half year later, we see it rolling back. So I wanted to start off by kind of giving these examples because unfortunately, we have a history and yet some are very current.
Thank you, Michelle. And it's horrific to hear not only the challenges that they face to access health services, but also to see how politicians and extreme politics use healthcare as a tool against migrants and refugees. Peggy, we're going to talk about women's rights and reproductive health, and it's a shame that in the 21st century, women and girls, although with the growth that we've witnessed in the past 30 years and the advancements of women's rights and women rights movements, still they face the threat of losing some of their sexual and reproductive health and rights. How does the erosion of rights, especially in the context of populism and extreme politics, affect women and reproductive health and rights?
Thank you very much. And thank you to Milka and and happy birthday to Aoife. And just brought to mind that the 90s was also the time of the Maastricht Treaty and the Amsterdam Treaty, when Europe got health as a mandate. This is the first time it got it as a mandate. And I think 30 years on, I mean, the Institute is nearly as old as Aoife. We're celebrating our 30 years next year. But, you know, also gender equality was first enshrined in EU law in 1957. With the Treaty of Rome, which was mainly an economic treaty. But under this EU treaty, many countries in Europe have flourished, but not one country in Europe has gender equality. And I think this is a sad statement to make in nearly 70 years later. But yes, the erosion of women's health rights usually happens in populist times and in times of humanitarian crises and also conflicts and war. And restrictions are usually access to sexual and reproductive health and rights, and also to effective and good quality maternal health services. And really, if we erode good mental health services, we are affecting not only and impacting on women's health, but we're also impacting on future generations and children. So it is a huge issue. And I think the last number of years, particularly the last 10 years, we can see that humanitarian crises have impacted disproportionately on women and young girls, both mentally and physically. And if we don't take the gender dynamics into humanitarian crisis planning, we are missing opportunities to support and help and progress the health of those who need it most. So that is a huge issue. Also, I think it was mentioned this morning, the pandemic and also the Ukrainian crisis has also impacted women disproportionately and also young girls. Usually what happens in situations like this, there's a highlight of the gender and structural inequalities that are happening in different countries. And also it gives rise to the pre-existing stereotypes and discrimination that women have had to suffer in these countries, which is huge issues and hugely different in different countries around Europe. What I'd like to say now about the capacity to access sexual and reproductive health really lies with the populace and the political environment. This is a huge issue. We've seen huge changes over the last 10 years, particularly the rise of the right, and also the disproportionate impact this has had on women globally. Not just in Africa, but in the USA and also in Europe, where we have some of our own countries see gender values and equality and human rights as a threat to institutions and individuals, and particularly to politicians who want to gain and regain power. And this can be seen in Europe, in some of our own countries. So the erosion of women's rights as continual, I mean, in times of crises and in times of war and conflict. And as you said, Michelle, in times of Ukrainian crisis, we have huge numbers of women and young girls, the highest proportion ever, coming to and around Europe. And without any legal status, without access to housing, healthcare, and maternal health care, their human rights are being eroded, and they're at huge risk of trafficking and also of gender-based violence. And their rights are being eroded, even in situations, in humanitarian situations where the security and the protection isn't even sufficient to protect their rights. During erosion of rights for women and young girls, we see that there's a lack of education, a lack of access to services, and a lack, also they receive bad information and incorrect information, which is never corrected. And also you see young girls and also young boys going online for information that they cannot access locally, which also has its own dangers and can also promulgate violence against women. So I think we have to be mindful moving forward that in times of economic crisis and pandemics, etc., it is women and young girls who suffer the most. And in making any planning moving forward, I think it behoves the policymakers and also civil society organisations like ourselves who are working for our constituent members, that we are actually supporting them and working to make sure that their human rights are not eroded. And one last thing I'd like to say is, I remember when I was studying political science, health was a public good and it wasn't a commodity. That narrative has changed now. And I think a lot of that has changed because economics has become the most important item. But I think we cannot have healthy economies if we don't have healthy people. So I think policymakers are missing out there.
Thank you so much, Peggy, and thank you for drawing for us the picture of seeing sexual and reproductive health and rights not treated as an essential service, and especially being threatened at times of crisis. And also reflecting on what you said about misinformation and the risks of using social media as a tool, which is something that we can't turn a blind eye on, and brings us to our next topic and important discussion about how politicians and extreme politics use social media to influence people's perception of health. So Naomi, can you tell us what are the ways in which social media can be used to shape people's perception around the right to health?
Thank you. but well, and yeah, of course, I'm a digital native, so I've been on every social media. So for me, saying social media is like saying everything and nothing, because Twitter now is X, Instagram is dying. We have the new algorithm of TikTok, who's basically shaping our own lives. And they know, politicians and especially populist politicians, how to use those tools. And what is important for civil society organizations and also more socialist organizations is to regain those spaces. A social network is a space. And especially after COVID-19 started, we were really missing spaces. We were really missing communities. And people were trying to connect with each other through spaces as social network. In those occasions, even though the common rhetoric was social media are a danger, are full of misinformation, I noticed something that I didn't expect it. People were actually building a community of care. A revolution of care was starting, and a new, I would say also a new feminist wave, Peggy, was starting, a digital one, a one where people were sharing information that were not always accurate, that's true, but because we were building our own knowledge, our own knowledge and awareness. When I was like studying, I decided to do like a thesis on menstrual health, and it was so weird for some, I don't know, for my professors at that time. But I now notice how many more women are now treating like their health, their menstrual health, their sexual reproductive health as something not to take for granted. Our pain is not normal. And only 5 years ago, that wasn't the case. The menstrual pain was normal. And on social media, this started. The conversation about pain started, about not being recognized. And I see mutual aid between women, because I'm part of the women community, but I can speak, I think, about minorities in general. People are sharing information and are willing to make those available. So awareness, building trust, building communities, I think it's something that social media can do if used in the right way.
That's great. Thanks, Naomi. And speaking of social media and digital platforms, I'm not sure if this is the time to involve our audience, or are we going to have the question? So, of course, we would like to hear from you as well. And so, in one word, what is the largest barrier to realizing health as a fundamental right? We want to see more active answers. We can see some highlighted words such as capitalism, neoliberalism, neocapitalism, complacency, capitalism again. Compassion fatigue, information echo chambers, funding gaps for NGOs, stigmatization, silos and compartmentalization. Sorry, very long words. So I think what we are seeing here is some of the things and the challenges that we have already reflected on and discussed. And so you won't accuse my panelists of being pessimistic, of shaping the current situation and reality we live in. We need to shift the discussion to a more positive note and discuss what strategies we can do to address health in the context of extreme politics and populism. So we're going to move to the second segment of our discussion. And Naomi, you finished with highlighting how social media can be used as spaces for women to connect and reflect on the issues that they face. And Peggy, you mentioned earlier how in extreme environments and crisis, women and girls are always the first to suffer. And as a woman myself in working in clinical medicine, I still find it really hard. And there are so many challenges for women to reach leadership positions in global health, although 70% of healthcare providers worldwide are women, and health exists on the shoulders of women as well. So drawing from your experience, what strategies do you believe are essential to promote gender equity in public health and shape inclusive social policies across Europe?
Well, I mean, I agree with all the statements there, all the wording there. I mean, I think we need to change the narrative, and I think we as civil society organisations, together with policymakers, we need to start having a different kind of discussion. I mean, I agree with you. I mean, when we started off at the Institute, we were talking about the lack of disaggregated data, the lack of women in clinical trials, and really that we were not taken seriously. And it's taken us so long, up to 2014, when the European Clinical Trials Regulation was being revised. And then we worked, collaboration is such a great word. We collaborated with other organizations in Brussels to make sure that age and gender were included in the new revision. So, I mean, I think that's an important one that we achieved together. So I think, you know, now the implementation of that directive or the regulation took place in January 2022. So has it been implemented? How is it being implemented? Who's aware of it at national level? So that's one area that I'd like to sort of concentrate on. The second thing is that the European Institute of Women's Health is launching a European Women's Health Interest Group in the Parliament on the 23rd of October. And we're supported by many MEPs who also are supporting our manifesto, together with NGOs, patient organisations, over 30 of them, and academia. And I think that's what we're trying to do. We're trying to change this narrative that, you know, we need to look at women's health and gender equality across the healthcare continuum, from the design of the research protocol right through to the implementation of services. Otherwise, we're not going to get anywhere moving forward in the next mandate. And because we waited nearly 70 years and nobody's achieved gender equality, I think there's a huge onus on the next mandate, both Commission and Parliament, to make sure that, you know, we move this forward much more strongly than we have done over the last 30 years. And also, I think we're just looking, I just made a few notes on what other people were saying as well this morning. And because we are in a changing societal state at the moment, and as you mentioned, the workforce, 78% of the workforce are women, and 51.5 are doctors, and 78 of nurses and midwives are women. And, you know, there's a gender disparity in favour of men. And I hate to say that, but it's ridiculous, absolutely ridiculous in this day and age. So what we need to do is we need to invest in female healthcare workers and change the narrative. We need parity at senior level, senior management level in healthcare organisations and in government bodies as well. We need to recognise the fact that women are the cornerstone for driving good health care at a European level. And this morning I was listening to BBC News, and I was listening to the news horrified. I don't know whether you heard it or not, that female junior surgeons in Britain still suffer harassment and inequities the hands of their senior consultants, which what's happening? 70, what have we done? What are we doing wrong as civil society organisations, policymakers? We need to have changed this discussion, and to change it as a matter of urgency, I would say, and make sure, hold account. I think Maya said, or somebody said this morning, about holding people to account. Apart from ourselves being held to account, policymakers need to be held to account as well as to what's happening in relation to gender equality. So I think politics and legislation, I really am a firm believer in good policy. As a political scientist, good policy, good legislation. And in our manifesto, we've highlighted all the plethora of EU legislation that impacts women's health, both social and medical. We have the gender equality strategy, the EU Beating Cancer Plan, digital health, European health data space, work-life balance, pharma strategy, clinical trials. There's a huge number of them. But if health policy is developed, what is happening to implementation. Is implementation part of the design of health policy? I don't think so. Who's monitoring the evaluation? I just want to give you, not to end on I want to end on a positive note. Looking at my own country and the Department of Health in Ireland, I co-chair the Women's Health Task Force in the Department of Health in Ireland. It was set up by the Minister in 2019. And this is kind of an argument to state, although we've been fighting for disaggregated data and an evidence base, because women's evidence base is not robust enough, because we haven't been included in clinical trials to date. You need more than evidence base. You need strong leadership and a multitude of stakeholders to change any type of policy. So in the Department of Health, we worked very strongly over the last 4 years to have a model an open policy dialogue, collaboration with healthcare professionals, policymakers, civil society, women's health organisation in a co-creation perspective, so we could actually co-create policy together. And I won't go into any more details, but we did have a radical listening exercise with women to find out what they thought of the health services, both good and bad, because the objective of the task force to improve health outcomes for women. And we did have this radical exercise, and from that came 3 main points. They wanted to be taken seriously, they wanted to be listened to, and they wanted respect, and they wanted better health information so they could make better choices. Not only that, the Women's Health Task Force became part of the programme for government. This was supported by all the constituent stakeholders involved, and it also received a budget, because if we don't get a budget, we can't do anything. So we're now into our second action plan. We launched the first one last year. The second one will be launched next year. So we're into our next stream of rounds of negotiation for the budget in October, etc. But what we'd like to see is more collaboration among all the constituent civil society organisations, because there's such a plethora of expertise in IFA, in EPF, in all the organisations, in EuroHealthNet, all in Brussels. I mean, it's such a fantastic support mechanism there that we can use moving forward. So really, I think really moving forward, the mandate has to be better legislation, better policy, and better implementation. And I think we could do it together. We can put our proposal together for the next mandate, both Commission and also Parliament, and hold them to account. Because we do need better information. We need to reduce this disinformation and misinformation around health. We need to create more awareness and health literacy from starting in schools right through across the life course. And I think then, you know, working together, I think we can do it. We can achieve equity. Sorry for going on so long.
No, thank you so much. These are like amazing messages and examples of strategies that we can do, and reminding us as civil society groups about our role and our duty to champion women to be and continue being in leadership positions. Jonathan, we move now back to populism, politics, and public health. And since we're speaking about strategies, how we can flip the coin and utilize ourselves as public health advocates, politics on our side, how can we bridge the gap between scientific evidence and public policy when populist rhetoric undermines trust in expert guidance? And we've seen this a lot during the COVID-19 pandemic as a tool that is used against scientists and researchers. So how can we address that as public health advocates?
I think to a large extent, we have to realize that, you know, the scientific evidence doesn't really matter, or it isn't of primary importance. So let's just think about the COVID pandemic, as you said, and vaccine hesitancy. If we take a step back and consider vaccines and mass vaccination programs, it's quite clear that that vaccines are perhaps one of the most remarkable technological inventions humans have ever come up with, and mass vaccination programs have created, you know, enormous public health benefits. You know, literally save millions of lives every year. The evidence is clear that the benefits of vaccines massively outweigh any risks. And still, during the COVID pandemic, and still today, there's a significant proportion of the population that don't believe the evidence, that reject it. despite the fact that it puts them in harm's way and puts their kind of fellow citizens in harm's way too. And so I think we have to consider why this is, and this is about something much bigger than public health. I suppose if we go back 30 years, as people were saying in the first panel, there was much more optimism than there is today. You know, it was a period of higher economic growth, of a rapidly expanding welfare state, of great technological change, and one in which people believed that their future was getting better and the future was going to be better for their children. But I think a significant proportion of the population no longer believe this. They feel left behind, and they feel like there's been a breakdown in many ways in the social contract. And this manifests itself in multiple ways: in voting for right-wing populists, in believing that the earth is flat, and in rejecting the advice of scientists and public health advocates. And I think we have to approach this with humility, really, and really try to understand the root causes of this. You know, of course, it's totally counterproductive not to get yourself vaccinated, but it's also rational to be skeptical of pharmaceutical companies that produce vaccines, because if we look throughout history, there's been all sorts of incidents where pharmaceutical companies have acted in their own interests and not in the greater good. It's also perfectly rational to be skeptical about politicians and whether they have our best interests at heart, because if we look at certainly in the UK, the policies of the last 10 years, they've had a devastating impact on public health for many people. So I guess in some respects that makes the problem more difficult, but it really means that as public health advocates, we need to be engaged in politics, and that is a massive part of the struggle. We can't just go with orthodox techniques of trying to educate people about the benefits of certain public health interventions. We have to look beyond that and try to understand why these interventions aren't being accepted, despite the benefits being very, very clear, obvious.
Thanks, Jonathan. That's very interesting to hear how one of the ways in which we can address that is actually being engaged with politics and trying to understand the roots of the problem instead of just focusing on spreading awareness, which is something we've been doing all over the years, but has it actually got us so far or to where we should be? Michelle, we move back now to undocumented migrants and refugees. And as civil society groups present here today, what steps can we do in order to advocate for the rights and health of undocumented migrants, especially in the contexts where populist narratives may be prevalent?
So one of the reasons why I find it very interesting as PICUM to work on health, because we work on so many different issues. We're, in a sense, we're a migrants' rights organization. We have a human rights approach, so we consider many different human rights. So labor rights, education, health, etc., gender. But health, from our perspective, and we're a little bit younger than EPHA. We're just about 22 years old. But we've also seen a huge evolution and devolution over the past 20 years in health. And health, for us, when we talk about undocumented, is very dynamic. So when we started in 2001, there were already 3 countries in Europe that had already adopted legislation on healthcare for undocumented, which is very interesting because it's not really a conversation starter. It was France, Belgium, and Italy. So we already had some experience kind of within the European region. And when we started, our members were telling us, we want to know what our country's legislation is, policies, legislation. We want to know that, but we also want to know what our neighbors are doing. So for us, one of the key points in terms of how to build up civil society's kind of capacities around such a difficult issue, for us actually was evidence to begin with, but it's only because we didn't have an evidence base. So we had the EU, which adopted in 1999 the Tampere Agreement, making migration and asylum a common EU policy. But it was really looking at 4 key areas. One of them was preventing irregular migration. So preventing people from coming in and trying to facilitate return or deportation. But it didn't really talk about the fact that there were at the time millions of people who were undocumented and in a sense with health needs. So our members were dealing with them. They were receiving people and they needed to know. So evidence building is part of it. The Fundamental Rights Agency did a major report in 2011 where it mapped out the EU27 and it looked at healthcare entitlements for undocumented. That in a sense kind of put it on the map, pun intended. But basically what we've seen has been really, really instrumental is a combination of service provision and advocacy. So I mentioned those 3 countries that had the legislation, but what we also saw then, since we have been founded, is in some regions which had very restrictive legislation, so Scandinavia, in I would say the past 15 years or so, there started to have the development of health clinics for undocumented because the state legislation for healthcare and undocumented was restrictive. So Doctors of the World, small healthcare clinics, some of them working with cities in Oslo or Stockholm, even Helsinki, they started to develop. And the reason why I want to talk again about Sweden, which I mentioned earlier, is because over 15 years, we had a major campaign in Sweden, which started very small with some of these clinics, and then got to be so big that it had about 80 participants or organizations, including all the major trade unions on the Right to Health initiative. And basically they had the visit of the former special rapporteur from the UN on health. They had a huge, huge parliament inquiry, and the law was changed in 2013 to broaden the coverage of undocumented beyond kind of emergency paid for healthcare. So they could have healthcare that was what is it called? Basically a little bit beyond necessary. So it was a huge, huge achievement. That's why the recent agreement is so devastating because we've seen what is possible with a whole combination. I thought it was interesting, Peggy, how you were saying it's never just kind of one thing. It's a combination of things, multi-stakeholders. Finland used the Swedish model, and they also had a campaign that lasted 10 years. So these are really interesting examples that I think can provide inspiration as well.
Thank you so much, Michelle, for these inspiring examples and strategies. And finally, Naomi, speaking of strategies that civil society groups can use to address misinformation and conspiracy theories that threaten public health around us on social media, can you share some of your thoughts on this?
Of course. As Jonathan was saying, unfortunately, scientific evidence-based actions are not always enough. That would be great, but unfortunately, we have to bridge the gap between where populist rhetoric is and where institution lacks their space and their power in convincing people. I want to make an example about that. When I was in Italy, I was an advocate for a pro-choice gynecologist, that's how we say, association. And in that time, the news about the morning after pill being poisonous for women's body was everywhere. And the campaign about that was a very, very shocking campaign. They had a picture on social media walls everywhere about a woman eating an apple like Snow White and dying because of having taken an abortion pill. So that was so good and well made that was really hard for us to counteract this misinformation. And I think civil society really have to step out of the comfort zone of being a little bit polished, a little bit too well put, and be in those places where these things happen. Of course, like in the EU bubble, we don't like TikTok, I get it. We don't like being on Instagram, but we have to understand how these things work, how and where those information are shared to counteract them. Us, by like what we did was being on Instagram every day. And us as activists, we were not gynecologists or obstetricians, but we were contacting them and trying to bridge the gap between our friends, because at the beginning you were like just women of the same age asking for, is this true, is this not? And the scientific communities, those doctors and medical professionals that could not translate those words into informations available and fruitful for women and girls. So I think what civil societies can do, and they're already doing it, and I'm proud that Aoife is really on with the social media. I'm sweating back there, doing the comms team, is using those tools, not celebrating those tools, but like understanding them and using as a weapon against who really knows how to use it.
Thanks, Naomi. And I think 45 minutes is never enough to talk about politics, populism, health, and human rights. But I think we've started the conversation, and that's a positive note itself. And I just want to ask my panelists to end with one sentence each, and only one sentence, because we're running out of time. So how can we ensure that the right to health transcends political ideologies and remains a universal priority? In one sentence.
One sentence, okay. I think we have to become the populist voice. All of civil society, we have to become a populist voice, work together, collaborate to make sure that public health has a rights-based approach, because that is what it is. Public health is a rights-based approach.
Just to say that public health as we know it can't coexist with right-wing populism. So we have to see it as an existential threat to our project and fight it.
We have to build on evidence and experience of policies that do work and that are inclusive. And while we're doing that, we have to make sure that they are always inclusive and that undocumented should never be reported to immigration authorities. And while we're doing that, it's still one sentence, making sure that we're multi-stakeholder in our approach.
I think we have to start focus more on the care part of healthcare, in the sense of taking care of the other one, mutual aid, and fostering a revolution of care and community.
Thank you. Thank you so much.